Dear Pure Urology viewers, good evening one and all. Today we are discussing about the port placements in the using the SSI Mantra robotic system. First of all, in laparoscopy, we put the ports with certain principles. Whereas in robotic, whether you use any type of robo, there are different principles. In laparoscopy, it depends on various factors like the habitus of the patient, the position of the patient, the height of the surgeon, the height of the table, the type of the surgery, all these things to improve the ergonomics in relation to the surgeon and patient. Whereas in robotics, port placement is to reach the object and rest of the surgery is done with the arms with extra movements inside the abdomen. So here, me and Dr. Hemnath, who has maximum experience working both together with SSI Mantra technology. Since the day of starting of the SSI Mantra at our hospital, Preeti Kidney Hospital, Dr. Hemnath assisted all the cases. We did 220 cases so far. Usually, the surgeon who assists will have a lot of idea about the robotic technology. Whereas in laparoscopy, surgeon who is doing the surgery will have an idea about the ergonomics because he has to remove the instrument and put suction. He has to take the needle holder like that. Whereas in robotics, the surgeon assisting will have almost 30 to 40% involvement in the robotic surgery. One such consultant is Dr. Hemnath, taking his vast experience because he is the one who puts the ports, he docks the robo. So he got 220 cases experience. So I thought of taking his help to conduct this session where if anybody wants to use laparoscopy or robotics, this session will be useful. Because we are working together and we are co-partners, I have recorded the video, making it as a semi-live presentation. Dr. Hemnath will clarify in between the discussion, whatever I am doing. Otherwise, we'll play the videos which are recorded. While performing the surgery of partial nephrectomy, we recorded exclusively for this purpose. So now I will introduce the Hemnath, Dr. Hemnath, and then conduct the program. Centimeters. So, Dr.
Should I share from my side, sir?
No problem. So, Dr. Hemnath is talking about port placements and docking with SSI Mantra robotic technology for various abdominal surgeries. Dr. Hemnath is MS, MCH gold medalist, consultant urologist and robotic surgeon. He did MBBS from Karnakumari Government Medical College 2004 to 2010. He is MS General Surgery, Government Stanley Medical College 2011 to 2014. MCH Urology, Madras Medical College 2016 to 2019. Fellow in Endourology and Laparoscopy at Preeti Hospital 2019. Consultant Urologist Preeti Hospital Hyderabad 2019 till today. Recipient of Professor A. Rajashekaran Gold Medal by TN Dr. MGR Medical University 2019. Recipient of Professor Rajashekaran Gold Medal by Madras Urology Society 2. Performed live operative surgery ultrasound guided supine PCL in March 2024. He got second prize in USA Best Video 2022. The abstract published in AUA 2023, TFL in RIRS for large volume stones. Co-author chapter on ureteric stricture in Grand Rounds in Urology 2025. Publication in national and international journals. Field of interest, endourology, laparoscopic and robotic urology. Now, let us start with the discussion. Dr. Hemnath,
Yes.
thank you for the efforts to record this video. The first question I want to ask you, you have the experience with laparoscopy, you gained laparoscopic suturing experience, you gained now SSI mantra robotic port placements and assisted 220 cases. What do you think in laparoscopy versus robotic? In which cases we keep more ports and why?
Obviously, in robotics, we tend to put more ports there because the assistant ports are separate and the working ports are separate. Whereas in laparoscopy, they are interchangeable. Working ports can be used by the same surgeon as like suction or introducing needle. These ports has to be separately put for robotic surgery. So robotic tends to have more ports than laparoscopy.
Hemnath, do you believe in laparoscopy when you are putting the ports, do you believe that there are fixed landmarks? The people say, I will put 5 centimeter above anterior superior iliac spine. I put 2 centimeter below xiphisternum. Is it correct to talk like that?
No, sir. Every patient is different, and we have to consider the height of the patient, width of the abdomen, the fat, obesity. All these things has to be taken into consideration. There is no fixed port positions. It varies case to case.
For example, if you wanted to do nephrectomy, what is the difference between a small child 5 years and when you are doing obese patients? How do you plan laparoscopy port?
So, in case of children, the width of the abdomen will be very less. So, usually we tend to stay in the midline for children so that our port, after the port, the camera has to go inside a little bit for us to see properly, and working space has to be there. If you go too lateral, close to the target organ, we will not have that working place. So in obese wide abdomen, we can go close to in the para-rectal line we can go. Whereas in children, we have to stay in the midline. That is the
Very
difference.
obese patient, too much obese patient, you will go where for laparoscopic nephrectomy?
No, obese patients,
You will go more lateral.
yes, sir. We have to go more lateral because the abdomen will be wide and the pannus, the thickness of the fat also will be more. So if we go more medial, then we have to travel long distance inside that pannus and also the abdomen.
Okay. In laparoscopy, because lot of the audience will be interested in laparoscopy, very few people will be interested in robotic, especially SSI mantra, because all may not have the same robo. So we will combine the discussion comparing the laparoscopy and robotics. In laparoscopy, the right hand port and left hand port, lot of people say that I will put 4 finger bits right side, 4 finger bits left side. Is it this way correct, or you better see the angle of the point of the interest and then keep the angle constant? What is most important?
Yes, sir. As you told, the four finger breadths may not be a good proper measurement. We have to keep the target organ in front of the camera. That camera has to be in front of the target organ, and the two working ports can be kept over the abdomen in a ergonomical position after the patient is positioned, like for example, oblique left up position or Trendelenburg position. Whatever position you have to keep
That
that
means
position.
you mean to say the right port and left port in any laparoscopic surgery, you will put after positioning of the patient, whereas
Definitely.
camera you will put before positioning. Is it correct?
Yes, sir. The ergonomics depends on these two instruments. So the next 2-3 hours you have to spend holding in that position. So you have to be in comfortable position. The patient has to be in Trendelenburg position, and then only you have to decide the working ports.
Okay. So if you are keeping with ergonomics like 45 degrees, 45 degrees on either side of the camera and then do the surgery, where do you exactly incise the skin in laparoscopy, right port and left port? You are keeping 45 degrees. You already place the camera port aiming towards the object. For example, in nephrectomy, camera port is placed at which level? In relation to umbilicus only we will talk, na?
Yes, sir.
How
So it
much
will be
it will be roughly where you will
four.
keep the
Yes, sir. 4 finger breadths above and lateral to the umbilicus is the standard position. It
okay.
varies. It can vary depending on the patient also. And
Hmm.
after that, we will keep two instruments, keeping the hilum as the target, and then make it a triangle-like fashion. And then half the instrument we measure, and then we mark the skin incision in that half
Y-
the length.
Yeah. Usually, do you think that these ports will fall in front of the camera port
Yes, sir. In laparoscopy, it falls in front of the camera port so that it
on
forms
either
a
side
baseball.
separated by 40 degrees like that?
Yes, sir.
Yeah. So if you wanted to put any suction port or clip applicator, anything extra for the assistant for retracting the column, what is the ideal position?
So it has to follow that curvature. It can go either away from that your right hand working port, or everything should fall below the this U line. So
So you mean
the
to say that any port you are placing to do any assistance should be below your two ports which are on the right hand and left hand, so
yes,
that assistant will come under the arms. Is it correct?
yes, sir.
Under the arms of the surgeon,
Yes, sir. So that we can
or
avoid clashing.
completely away. You said that it should be in the iliac fossa to retract the gonadal
Yes.
ureteral packet, so that he is not at all in coming line with the surgeon.
Yes, sir. It should not fall in line so that to avoid clashing with the instruments. So it should either go away from the right hand port or left hand port, or it should fall below the line of the camera. In
When you are
between
doing
the
radical prostatectomy, VVF repair in laparoscopy, how do you assess how much above the pubic symphysis the camera port has to be kept? Is there any logic?
Usually we keep that camera in the abdomen, and we will mark the midway of the camera in the abdomen. Usually it falls above the umbilicus. If the patient is tall, it may fall on the umbilicus also. So depends on the height of the patient. If the abdomen is length is long, then it may go close to the umbilicus. If it is
So
short,
the
it will
you
go
wanted
above
to
the
take
umbilicus.
criteria the length of the camera as the length of the camera, half length above should be the port.
Yes, sir. Yes.
Minimum.
Yes.
Benefit
Yes.
of doubt, you will go more higher or you will go more lower,
Always go away than close.
go away. What is the reason?
So if it falls short, it's a problem, sir. If we are away, we can push the port a little bit inside also, and we can
Oh,
adjust. But
okay.
once we are fall short, then it becomes a vertical operating field. Then it's difficult.
Okay. So in laparoscopic surgery, if you are doing at the pelvis center, hmm, you do in the midline camera port normally.
Yes, sir.
In renal surgery, you will do four finger bits above and lateral to the umbilical this thing. What about varicocele surgery? What about ureteric reimplantation? What about adrenal surgery? How do you plan the ports laparoscopically for these?
So for the pelvic surgery, if either right side or left side we are doing, for example, ureteric reimplantation, Bovary flap, all these things, we keep the deep inguinal point kind of thing. We direct the camera port in front of it, and then everything will be screwed slightly oblique, not in the midline central like this. Everything will be slightly skewed in the oblique angle. So keeping the target as the either right side ureter or the left side ureter, or varicocele also same way. Same opposite, we have to go for the adrenal gland or the gallbladder surgeries or splenic surgeries or liver surgeries. So we have to keep it like
So
slightly oblique.
the on the abdomen, they will not be in the midline. They will
Yes,
not follow any curves. It will be based on the end organ. What you mean to say that
yes,
if deep inguinal ring is kept, it may come above the umbilicus to the opposite side, above the
opposite.
umbilicus to the opposite side, and two ports may come anywhere between these in front of this umbilical port.
Yes, sir.
Now, for the audience sake, we have recorded. We will go because I asked questions to Hemnath. Hemnath has given live in the robotic. At the same time, I asked the laparoscopy also. Because we have experience with SSI mantra, we are sharing only SSI mantra related ports placement. In 90% of the cases, I think all robotics will have the same concept. We also discussed the laparoscopy in between. Now I will open and
Yeah,
share the uh,
I
see.
will share, sir.
If you share, you share because there is no problem.
Yes, sir.
If you have that, you share. It's better. Dr. Hemnath, when you perform any laparoscopic surgery, I am not seeing
and
anything, Hemnath.
robotic
It
surgery
is
with
only
SSI mantra,
no, Hemnath.
what
I
is
am
the
not
basic
seeing.
difference between the port positions?
I am not seeing anything. You have shown the presentation. If you want to start the presentation, you start it.
You're not hearing the voice, anything, sir?
I am hearing the voice, but no video. Now it is the first video. Correct. You play it.
Dr. Hemnath, when you perform any laparoscopic surgery and robotic surgery with SSI mantra, what is the basic difference between the port positions?
So in laparoscopy, our main aim is ergonomics. So we should be comfortable in doing surgery. But in robotics, it's not so. So we can slightly adjust. So in laparoscopy, any laparoscopy and robotic, the camera port will come in front of the target organ. But in robotic surgery, at least we should give minimum of 12 to 15 centimeter for the camera port from the target organ. Supposing this is a case of partial nephrectomy, so kidney will be here. So our area of interest will be hilum mostly. Our camera port will be minimum of 12 to 15 centimeter from the hilum. So our camera
It is
port
in
should come somewhere
laparoscopy.
here.
What about if it is laparoscopy? More or less same? That
more
point?
or less same, but we can go little closer to the target organ.
In laparoscopy.
Laparoscopy.
But in robotic, it is
robotic-
more or less fixed.
Yes.
SSI mantra, what, for example.
Because the port has some limitations. Give me a camera port. So minimum this much should be inside the abdominal wall for the robotic port. For us in laparoscopy, we can keep a little bit inside only.
So in robotic, fixed distance is acceptable from the target, whereas in laparoscopy, you have to adjust according to the width of the abdomen and the age of the
Yes, sir.
patient.
If it is a wider abdomen, we have to go more lateral. If it
But
is
in
a
robotic wider abdomen also, you have to keep minimum 10
minimum,
centimeter,
12 to 15 centimeters.
12 to 15 centimeters. Now, Dr. Hemnath, please show where is your point of camera port in various surgeries of the abdomen.
So we'll start from the left upper quadrant. Supposingly we are doing like left adrenal gland or splenic surgeries. Our target organ is this one. So our camera port, as I told you, will be straight in front of the target organ. So it will come somewhere periumbilical region. If it is a wider abdomen, probably it will come slightly away from the umbilicus. If it is a thin abdomen, it will fall somewhere near the umbilicus. The arms, robotic arms will come and stay near the anesthesia machine here. So it will all come in this direction. The camera arm, the left working port and the right working port, they will all come from here, and then we will dock it from this angle.
Okay. Tell
And,
about the other
next-
surgeries.
Next will be our renal surgeries like pyeloplasty, nephrectomy, partial nephrectomy. So we will stay in front of the hilum. So supposingly this is the hilum, we will stay in front of the hilum here, somewhere here in the pararectal line. Next, if we are doing any colectomy or any general surgical cases in the left side of the colon, descending colon, same, we have to stay close to the midline. Camera port will stay close to the umbilicus and the other ports will come like this. If we are doing a ureteric reimplantation in urology, so our target organ will be here. For the camera port, we will come slightly above the umbilicus here, and the working ports will come here and here. So similar to laparoscopy, in laparoscopy we will make a triangulation for the working ports. We will go very close to the target organ like this. But in robotics, we will stay in almost a straight or a U line for the robotics. And then for the bladder surgery, patient will be in supine position with
Prostate, bladder, VVF, hysterectomy, all deep pelvic surgeries.
So patient will be in supine position with deep Trendelenburg position. And the
Will you put the camera port first in Trendelenburg position or in the supine position before?
supine position?
Supine position.
Only
So we are
before-
talking about the camera port.
Yes.
You will be in the supine position. Tell me the ports where you put in robotic.
So similarly for prostate or bladder surgeries, we will keep 12 to 15 centimeter. It will fall according to the height of the patient. It will fall somewhere above the umbilicus or at the umbilicus level. So mostly above the umbilicus is safer.
Is it safe to go a little above or below in robotics?
It is always safe
to go above.
Away, you should not err on the closer side.
Yeah.
You should stay
If same thing in laparoscopy, you put generally half scope above length.
Yes.
Can you take that scope and show? This is the scope.
This is the length of
This is the
scope.
length of the scope.
Best fulcrum
Put it on the this thing,
we
and
will
fulcrum
keep
should be half
half.
above. Where is
So-
it half coming?
So it will
Here.
come like
So in laparoscopy that applies.
That will-
Scope half length above.
Yes.
Whereas in robotic more or less fixed like 15
Yes,
centimeters.
Yes.
So these are the. What about the epigastric surgeries, gallbladder or
For any umbilical hernia kind of surgeries, we have to go to the lateralmost point in the abdomen.
okay, as away as possible.
As the way as we have to see the colon, white line of the colon, and stay slightly in front of it, and it will come in the.
What about the epigastric surgery?
Epigastric surgery, we have to go exact opposite. All the robotic arms will come on.
Then
the
what will the
head.
anesthetist mission? Anesthetist
They
will
have to
move.
shift
They have to
accordingly.
shift accordingly.
We have to keep all the arms here, and it will be like a opposite to the pelvic surgery. We
Okay.
have to plan accordingly. And if it is a gallbladder surgery, we have to. This is the gallbladder, and the ports will be, camera port will be here. The working ports will be here. So this will be the gallbladder.
This is not a horizontal line then.
It will be a lazy U kind of a line.
So whereas in laparoscopy, how do you put the gallbladder? We're totally different.
That will be a exact triangulation. We have to. That depends on our ergonomics also.
Ergonomics
we will keep
also.
the instruments in a proper way.
So
ergonomical.
more or less in laparoscopy, ports are according to the height of the patient, height of the table, abdominal breadth,
Surgeon's
age of the
height
patient, surgeon's view also. Whereas in robotics, surgeon height will not matter.
Will not matter.
Surgeon height will not
For
matter.
patient body habitus.
Patient body habitus, it will matter. If you wanted to put, Dr. Hemnath, the fourth and fifth ports for the assistance by the robotic surgeon, can you on the lights and show that? Dr. Hemnath, now the next question is how to put the second and third port in the or fourth port. Actually, SSI Mantra has 4 robotic arms here. How do you put the second and third, fourth? How do you plan? For example, you tell 2 examples. One is pelvic surgery, another is renal surgery. Because we are urologists, we will discuss in that angle.
So for the working arms, after keeping the camera port, supposingly this is a nephrectomy, we are keeping the camera port here. For the robotics
First, you tell laparoscopy. How do you plan?
laparoscopy, give me two instruments.
What instruments you are using? Normal
Any
instruments.
normal standard
So,
size instrument.
Instrument. These are laparoscopy instruments.
Laparoscopy.
So after putting the camera port,
So
you
after
will
putting the camera port,
One important point I want to ask. Before putting the second and third ports, will you change the position after putting the camera?
for
Definitely.
laparoscopy it's a must.
Must. For robotic, it is,
Robotic,
cannot be.
For docking, we have to keep the
We have to keep the position. You cannot do afterwards. So for camera port, supine is okay. For accessory ports, better to position and then put the ports. Even for robotic. In laparoscopy, you show me how do you put the ports.
So if supposing this is the target organ,
Okay.
the left kidney, this will be the camera port already we have marked.
Yes.
And to place the working ports, we usually keep two instruments.
Okay.
In your neutral standing position. With
Okay.
the patient at top of the patient at the level of your hip.
Okay.
So then you keep two instruments on the target,
Okay. And
And
they
then-
should be separated by
separated by minimum of
90
4
degrees.
fingers. And
90 degrees.
manipulation angle should be there, and azimuth angle should be kept at 60 degrees to 45 to 60
yeah.
degrees.
Now where do you put the entry point to the third, second port and third
So
port?
usually the same half the length of
Half
the
the length.
instrument we will keep.
That usually falls in front of the camera port, baseball.
Yes, sir. Baseball diamond concept should be
So
there.
camera will be the most farthest away in
Yes.
laparoscopy.
Yes, sir. Camera will be there, and in front of it the instruments.
Two
will
instruments will come.
come. And any assisting instruments will come
Behind that.
below the camera.
What about the robotic ports?
So robotic
SSI
ports,
mantra
we
related.
don't do this triangulation and all. We keep minimum of 8 to 10 centimeters.
For example, you show where is the camera port you planned.
So camera port is here.
Ah.
Minimum of 8 to 10 centimeter gap should be there between the ports.
Even children in infants, neonates.
That is must for
Must
to
these
avoid the clash.
these arms. Okay.
So here for the left working port,
Okay.
I am taking 9 to 10 centimeter. It will fall somewhere here.
Ah.
And for the right working port, we have to come here.
Okay.
Whereas
For
in
example,
laparoscopy, we will come more closer
anterior,
to the-
more closer to the object.
target.
Now imagine you are doing hernia like surgery, varicocele. How will come? Already you marked above the umbilicus.
Yes.
That
This
is the
the-
end organ.
This is the
This
camera.
is the camera.
For laparoscopy,
Generally, I prefer the pararectal than midline. Do you have any advantage in pararectal?
Yes,
Not.
sir.
Hernia chances will be less because posterior rectus will. Okay.
For
Same
hernia-
for this is laparoscopy. you are showing.
laparoscopy, we will put the port somewhere.
Somewhere
in the
here. Same
midline.
again, half level.
Somewhere here we will
in
put.
front of the camera. The
Yes.
baseball, can you draw, please?
Yes, sir.
For the hernia, baseball, what is happening? Yes. And the right side, like that. Right.
So this will be the.
This will be the baseball.
Hernia.
Now, what about the robotic? Same hernia
We
robotic.
cannot go here.
Yeah.
Because in the working port also you can see that marking.
Yeah. So
This
it will
much-
fall.
This much should be inside the abdomen. So
Oh.
if you keep it here, it's
What
already reaching
approximate
the target.
length of this second port and third port, Hemnath?
There are two lengths available.
One is pediatric.
This is actually bariatric length.
Ah.
So the other standard length is this one. You
Okay.
can see the difference.
Yeah,
For
yeah.
bariatric this is.
Okay.
But for all the.
What is the size of this?
This is around 20.
9 mm.
This is 9.
9 mm. So
this is camera port is 12.
camera port is 12 mm. That is a disadvantage of robotic. All robotic are like that. So while doing hernia, for doing varicocele, for doing ureteric
So-
reimplantation,
For robotic, we will come in a almost straight line.
straight line.
So we have to come see the difference.
Little farther.
Yes, it will come.
Few
slightly.
centimeter away, few centimeter lateral, and more or less
And,
one
10
line with
10
10 centimeter away from the.
each arm.
If it is radical prostatectomy, robotic second arm from third arm.
So
This is center.
Camera will be in the center.
Uh,
That depends on the number of arms. 4 arms.
Four arms if you are using.
So one side we have to accommodate the extra arm.
Okay.
So for the right side, if you are keeping the extra arm on the left
Extra arm right is better, left is better. In SSI mantra.
So here
Doesn't
left
matter.
is,
Left is better.
sir.
So you are keeping right side how many centimeters and it
10
is
centimeter we have to keep
horizontal
for
line or slightly lower?
Slightly lower we can keep for the right side, and whereas for the left side I will go slightly behind
Above
the camera
to accommodate
to
the
accommodate the next arm.
next arm.
So it will be like coming like this. Camera will go like this, and the right arm will be.
Okay.
So slightly a W kind of a configuration.
Yeah. This applies to VVF repair, everything.
All wherever we use forearms in pelvic surgeries, we have to use this.
Okay. Yeah. Now you have shown for renal surgery, for pelvic surgery, for inguinal surgery, you explain how, where you require actually other arms, why you require. One is for suction, another is for clip application, another is for insertion of the needle. So do you think 5 mm port is required or 10 mm port additional port is required?
If you are trying to use 3020, then 10 mm port may be required. Otherwise, 5 mm port is sufficient.
You do require 2 instruments, or see, basically you put 3 ports or 4 ports in Robo. If you put another 2, it will be nearly 6 ports. Where will you require these 6 ports? Which surgeries do you think?
If you want to have a constant suction, somebody to assist you with constant suction, and also some traction is required. One person will be doing suction, other person will be applying the traction.
So large kidney, large masses, large perihilar dissection. So if you want to be safe, you can put 3-arm or 4-arm robotic and 2 5 mm or 10 mm or 5 mm. You should not be hesitant to do that, isn't it?
Number of ports should not be.
Number of ports. So now you tell me, if you have put 3 ports or renal surgery, where do you put the accessory ports?
So
You already explained that. You have put one left, one right, central and right. 3 ho gaya.
So this should be the assistant. All the assistant ports should come below this line.
Okay.
Nothing can come
in both laparoscopy as well as
in laparoscopy
robotic,
also, but
because
even-
they will not clash.
Yes, sir. In robotics, you cannot keep any assistant ports in.
Because robo arm will
because
come.
arms will,
Arm will come.
So always it will come below the line of the ports, and for a safe manipulation, you have to have it in between these 2 ports.
Center.
How
far back? What is your experience?
5 centimeter of distance. It has.
If you go more back, the bowel insertion will be difficult.
It will be difficult. It has to.
Sometimes do you put these ports? Well in advance before docking? Also, it's worth.
Yes, sir. Mostly will.
If you have planned.
And unplanned also, sometimes you can.
It's difficult.
But blindly you have to.
Blindly you have to insert. Okay. Can you show the ports of the SSI mantra? Are they safe? Are they blunt?
These are very safest
ports.
Because these are
very blunt.
First insertion.
What are the other sharp instrument you show? Other 2 types. Yeah. That blue one as well as normal one. So can you show what is that? This is sharp.
This is sharp.
It
This
can
is
injure.
cutting blade, yes.
This is what about this? Okay.
This is also
Medium.
Yes, sir.
This is the least traumatic. But you have to apply more force. What is the tip and trick if you want to give for applying more force?
More of
Rotate and also cut the rectus sheath. Anterior rectus sheath, if you cut, the resistance at least will be for posterior rectus sheath. In pediatrics, it is very difficult because it's elastic and the strength will be more. Dr. Hemnath, what are the basic structural instruments, equipment needed for the SSI Mantra robotic system? You briefly tell.
Mantra system has 3 components. Main thing is this is the surgeon command center.
This is surgeon command center.
Yeah, this is an open console system.
Open console system.
And we have this switch pedals here.
Okay.
For the cautery, that yellow and the blue ones are for the
Cautery. What is that plus one?
That is top one is the master clutch. It will stop all the instrument movements, all the arm movements.
Below one is
Below one is the camera clutch.
Okay.
Pressing
What about this?
These are the hand controls.
Okay.
This is
this will work only in this space.
It will work in this square. It is
Okay. This is electromagnetic.
Yes.
Okay. This height can be adjusted with surgeon.
All the height can be adjusted.
Where are the cameras to the surgeon's movements? Those 2.
These are sensors.
Sensors. If you sit only, they will be getting operated.
Constantly it will follow the.
What is this this screen?
This is a central control center, and you can control the arms and also the software. Everything will be in this.
This is central control system. Yes, now coming to the basic equipment on the table. This is the
vision cart.
Vision cart.
And this is the arm cart.
These are the 4 arm cards.
Forearms. This is
In the
second
vision
version.
card, what do you have? One monitor, HD monitor is there,
Monitor and
3D.
the storage system.
Storage
is there.
system,
Olympus,
Olympus or
camera
any
system is there.
camera system,
Yes, sir. And the light source.
a light source. Below this one is the
These are the cables that are
cables that are connected to the interconnected to the
sir.
cards as well as this thing. Now coming to the basic equipment, can you explain?
So this is the camera that is provided with the SSI Mantra second version. 2.0.
Second version. Now
This is-
SSA Mantra has come with newer camera.
Yes, sir.
Yes.
So
This is flexible.
Flexible tip, zero degree tip.
Yeah.
And this is Olympus 3D camera.
Okay.
And we have a control over here to adjust the angle up to maximum 30 degree to 90 degree it can bend, but we will not use that much. So the disadvantage is it's a fixed 0 degree camera.
Okay. Now what about the other equipment on the table?
So you
Laparoscopy instruments are also you are keeping,
yes sir, for
and you are keeping standard robotic instruments.
yes sir.
And we are keeping the various robotic ports.
Yes, sir.
What are the ports you have kept here?
So
One
this
is
is
camera
the
port,
camera 12 mm.
and another
These
ones are the long, extra long
9 mm port.
9 mm port. Children, you will use separate ports,
Short length is
short length. What are these ports? Laparoscopy ports.
Laparoscopy ports.
What is the instrument? How it looks like?
So this is monopolar scissors.
Monopolar Caesar. Okay. What is the what is this base?
This will go and fix in the actuator.
This is the basic in any actuator. It will sit.
Yes sir.
The cartridge attachment is on the back side. Bipolar cartridge attachment is where?
So bipolar two instruments are
Two
there.
instruments are bipolar. One is
fenestrated, forceps
fenestrated forceps. Another one is
and Maryland is there.
Maryland is there. Where is the bipolar
This is-
attachment?
No, fenestrated forceps, but grasping forceps, but no
Bipolar.
bipolar. This will grip more tightly.
More tightly
Whereas this
than
grip will be
bipolar
slightly
grasper.
less.
Bipolar grasper, can you show where the bipolar is attached?
So this is where the cable gets attached.
This is the cable get attached.
This is the large needle driver.
Large needle driver.
So we have smaller ones and the extra large is also there.
Okay.
This is the
Basically,
medium.
okay, thank you. Dr. Hemnath, how do you insert the port into the abdomen? Do you use open method or closed method?
We use closed method, Veris needle technique for the pneumoperitoneum. So usually our safe point would be the Palmas point, that is 2 finger breadths below the rib cage in the midclavicle.
Do you palpate the liver and this thing?
Yes, sir, always palpate
Always.
the
And CT
abdomen.
also you might have observed.
Yes, sir. So 2 finger breadths we have to keep a stab. Veris.
And what is the important tips and tricks you give to the juniors when you are inserting the Veris needle?
So always hold firmly and
Firmly
the
and lift,
abdomen.
maybe 2 persons.
And hold the Veris as a pin.
Pen, okay.
And always check the Veris for the spring action and also flush and see the
Yeah, that you have checked.
movement. Yes, sir. And then there will be 2 clicks. So this
One.
is the first click.
Second click.
Yes, sir.
Yes, very nice. So now,
And this is safety precautions you have to take. First, you have to insert syringe and aspirate and see for the bloody contents and the bowel
Okay.
contents.
Mhm.
And push and see for the free flow of water.
Mhm.
And also drop test. You have to drop and then see whether it is sucked inside.
yeah. If it is in free cavity, it will suck it.
Yes.
Now you will attach the
Yes.
gas. What is the first thing you will see after attaching the gas?
The pressures we have to observe in the abdomen cavity.
Yeah.
It should be less than 10, preferably
Yeah.
single digit.
So now where is the pressure on the top? 4. 4 has come. That means it's good. 7 has come.
And the flow is
Flow is how much flow? Point
it will be around less than 2.
less than 2. What is the flow here you have kept? 1.5 to 2.
Yes, sir.
0.4, 0.5, that is a 4.
Go up to
2.8.
14, but that is for the port. Not
What is the set pressure is 16.
16.
What is set liters per minute is 4.
Up to now, till now, it 1.1 liters has gone in.
1.1. Usually by 3 liters abdomen gets distended. Now you have distended the abdomen with the uniformly distension is seen.
Yes, sir.
Now where will you put the port? You already mentioned that target organ. This is partial nephrectomy target organ, or you are keeping 10 centimeter away. What are the tips you will do? Now the marking is that. Now you will the vertically or horizontally you will incise,
Give a wide incision. So
wide incision.
and slightly give a nick on the rectus also.
That is a little subjective. You should be careful with the blade. Now when you are inserting, what are the important point you wanted to tell Hemnath?
So always keep a. So always keep your left hand as a control.
Yes.
That should not allow it to.
Yes, left
have a
hand as the
jerky
brake.
movement should not be there.
Yeah.
So and have a finger like this, so to guide you and also to support the.
Okay.
thing. And keep in a perpendicular direction, not like this, not like this.
Okay.
So perpendicular to the surface, and do screwing movements and little bit of forward movements.
Left hand is control.
When left
Right hand is
control.
going forward.
More of
So-
screwing movements rather.
Now you felt
it is
less center. Now left hand is firmly holding.
Holding.
Okay.
So now if you release, there will be
Gas will be.
That is
Gas
the
is
surest
leaking.
sign.
That is the surest sign that you are in the peritoneum.
Yes.
Dr. Hemnath, after putting the camera, will you check any injury, anything like this?
Always check the very side
Where is site? Now you are on the left side.
and also.
So colon is seen, intestine you are showing. And what is the port now you are going to insert under the vision?
all other ports under vision.
Already you explained how the port is inserted 10 centimeter above. Okay. Do you angulate this towards the object or you do not necessary?
The last point.
Last point you have to change towards the direction. Excellent point this is. So this is approximately 10 centimeter gap.
Yes, sir.
But almost below the xiphisternum. Dr. Hemnath, in this case, how many ports you are showing? 4 ports.
4 ports.
When you show the marking,
For the right side, we are keeping 2 arms there.
Ah.
So this cannot come in the straight line.
straight line,
So it has to.
you are
come
going
slightly
a little
angulated.
back towards the midline,
And the next
Then
port
curve.
we can come like this.
like this.
So it will be like this.
Like
going
this
down
and a little bit like W.
Yes.
If you are putting fourth arm, you have to give space for it.
Yes, sir.
That's why you are doing like this.
The time this port will come slightly
Okay.
down.
Is there any chance here in this inferior epigastric artery can come? No.
This has to be.
This has to be under vision. Okay. Now you are inserting the. Now we are inserting the right side
Right.
robotic port 8 mm, 9 mm exactly at the almost nearer to the umbilicus, a little not in the midline, little posterior. I mean little away from the target. Again you are holding left hand tightly
Sure.
and then you are inserting. You are able to see that. Very good arm strength. Very nice. So this is under vision. Where do you insert the fourth arm now? What are you adjusting here, Hemnath?
No, here it should not be too much inside.
Inside. What is the problem if it is too much inside?
Too much inside, then it will be closer, and the
Instrument,
stick inside cannula error will come in the robo.
Okay.
So-
If it is too much outside, it can come out.
It can come out.
So there is a mark there.
There is a mark there.
That mark is safe.
These are the markings. So up to this mark we have
This
to keep.
mark. That bigger.
It has to be at the skin level.
Okay, skin level. Bigger mark. This small mark, what is there on the behind?
That is the maximum.
Maximum you can keep inside. Okay, next are you inserting the fourth port?
Fourth port.
Because this is
under
partial
the-
nephrectomy.
So there we can see the.
In the fourth port is falling in the region of the inferior epigastric artery.
Yes, sir.
Now can you show there?
That is the
Inferior epigastric artery. You can see
So
that.
we
Now
have to come
you do
from
that.
here.
You okay? So you are adjusting a little medially. Okay. Bladder should be collapsed for this.
Yes, sir.
Yeah. Already catheterized. Okay. Now you are inserting, avoiding the inferior epigastric. Now can you go back and show the inferior epigastric artery? That is inferior epigastric artery. Okay. Now you inserting a little away from the inferior epigastric artery. Show that. Very good. You need lot of power for this, na? Blunt one. So he is applying power, but see now he got it. Definitely well above the away from the well above. Show that port. Show that port. Yes. Towards the object. Yes. Okay. Thank you. So these are the 4 port position for the. Can you remove your hands? This is the 4 ports. Now, do you think that you require any other ports in this surgery?
Definitely, sir.
What do you want?
For clip application, we need 1 port. Or if you are applying bulldogs or
Setinsky, in this case, you are planning Setinsky. Where will you put the port?
we have to come below the umbilicus level.
Umbilicus level. Okay. Can
And
you
1 more port for the suction here.
suction here? Can you put those ports? You are going again with the right arm. That is, you are adjusting that that side.
To accommodate these 2 arms.
These 2 arms. So total 4 arms. Now the SSI mantra has come with the small arms.
Yes, sir. Now the 3 over
3 arms has come. Now
5 arms are there.
5 arms are also there in the SSI mantra 3.
This is bulk.
Now you are adjusting with again port clutch. Anna?
Yes, sir.
All are towards that side only. Now you have come to the port.
I have aligned.
Aligned to the port. Now you are using the arm clutch.
Instrument.
Instrument clutch. The instrument will clutch and you are with port clutch you are bringing them.
Don't you back, little back, go back. Go back.
This main arm adjustment, what is the secret?
Sir,
Main arm you tell to
these 2
vent.
beams should not clash.
Those beams usually comes in one line.
Yes, sir.
Okay. Hemnath, you are coming with the 4th arm.
Yes, sir. This is slightly thicker.
This is the trickier. How to do that?
Short abdomen is there, it can clash.
Okay. In that case, can you increase the arm distance? No need. This base.
Yes, sir. We have to go a little wider like this and come inside.
You have to go little wider on the top. And then you are using the port clutch again.
Come close.
And now you are using the arm clutch. Port clutch you are using.
This is instrument clutch.
That is instrument clutch. Instrument clutch. After the instrument is got parallel,
Go back.
you are using port clutch now again.
Yes, sir.
So this is difficult. You are sitting almost. Sitting and holding the port clutch. Okay?
Yes, sir.
And you are fitting it. Now, will you check the clash for this?
Come inside with angle. Make angle. Come inside.
You are making angle. All are that side directed.
Come inside. Okay.
Now you are checking the angle there.
These 2 should not clash. So the important thing is this has to go up to the splenic flexure.
Okay.
So we have to keep it like this and check.
Okay. During that time it may not be moved much.
This will not be used.
Used
We are
only
operating on
on the splenic flexure. That is important point. Okay,
So
thank
now-
you. Hemnath, once you put all these 4 arms for partial nephrectomy, one is camera, one is 1, 2, 3, you have put according to your line. Now what is the next step?
Next is docking.
Docking means what?
That arms get fixed to the floor and it will not move.
These arms get fixed with floor. Can you show how it is done? What is these laser beams? You are doing it here, continuously pressing it, and it will get fixed. Everything. These lines, what is the importance of these laser lines?
That is next step.
Next step. Now you are fixing the arms. That means arms will not move. Arms will move, but basic base will not move. Base will not move. Only your these hands will move. Robotic arms will be moving. Yes. Next.
Once that is fixed, we will align these laser beams parallel to all the.
Now they are parallel or not parallel?
Not parallel. This is.
This is angulated.
So
What is this for? Parallel
This machine will understand that these arms are placed in this way.
in this way.
So this is for orientation.
Orientation. After that, what will you do?
They will do something called cart registration. So this cart is placed in this direction. We have to tell the machine.
How to do cart registration?
They will press that 2 times.
2 times cart registration. How do you know that these 2 times it's correct you are doing?
We have to see in that monitor.
What is there in the monitor? Can you show? This monitor is control,
Central control.
central control. This will be by the side of the surgeon.
So we are placed these arms in this.
These
direction.
arms, okay.
The correct align. This one is.
You see whether they are. How do you know?
Check once.
Where you have to check?
The cart registration they will do again. I think this is not oriented properly.
This is not oriented properly. What will you do?
Again they will do cart registration.
There is no need to change the arms at any cost. Whatever you have felt surgeon, it is over.
Yes, sir. Now it is actually ready for insertion of.
Registered, क्या था?
Over.
Registered. Okay. Next step is.
Now insertion of instruments.
Next step, Hemnath, tell me. Insertion of the instrument.
Camera and the
How are you inserting here?
So this is the camera.
Okay.
So there are 2 functions of this instrument clutch.
Okay.
If you press and hold, we can move like this.
Okay.
If you press and leave, then we can advance this like this.
Okay. Once press and leave, you can advance the
Advance the
arm inserter.
Instrument, yes, sir. So for the camera insertion, we have to keep it like this.
And then
place
go
it
there.
in the slot. And there is a latch here. We have to.
Where is
press
the latch?
This we have to press.
Okay.
And then this slot has to. Click sound has to.
It has gone inside.
Yes, sir. Now it is inside the port.
Inside the port.
Now I will advance by pressing it 1 time. I
You will advance.
Advance it inside. Now it is.
That is advanced. At what level you will keep? Object level anywhere. Center point. Okay. Now this is the adjusting of the camera. Now after adjusting the camera, what will you do?
Insertion of the working instruments under vision.
Okay. Can you show working instrument under vision? Why are you lifting that and showing?
So that entry point.
Entry point you wanted to show.
Otherwise
It may come blindly and injure. Now how it is inserted?
Monopolar scissors.
Okay. First you put into the port.
Put into the port.
And
2
then you will.
Fingers,
Ah,
and this is the actuator.
okay.
And just keep it and slide it inside.
Okay.
Then color will change. The light color will change.
Okay.
And the instrument.
Now instrument, how will you put? One time you have to press that.
1 time press.
Port clutch it is. What clutch?
Instrument clutch.
Instrument clutch.
So we can change the direction. Otherwise, if you insert like this, it will go into the bubble.
Bubble. So you have to
So-
put into the central part into the air. I mean into the peritoneal cavity
Yes, sir.
and bring that instrument from
Under
here
vision like this to the
like
target.
this towards the object center of the surgery. Okay. This you have inserted.
Now next is
Next is again you are moving to show the other port entry point. Now you insert
so this is bipolar.
bipolar
fenestrated grasp.
bipolar fenestrated gas tap, and then
Once it is instrument homing will happen there.
yeah. Now once instrument inserted, you are using the instrument clutch and bringing them with vision. All the 3 camera, 2 instruments are in line. This is complete port the insertion of the instrument and attaching the
These are the cautery cables.
cautery cable. This is a bipolar cautery cable. Caesar has monopolar cautery cable. Any cautery will do or fix it. Better use
Company has
company recommends Valley Lab.
So
Valley Lab. Now this is the 3. Now you don't want to use 4th arm now.
we'll just insert. The
We'll
instrument.
insert the instrument just up to the level of the port.
Yes.
But this 4th arm better not to use now.
Yeah.
Only necessary while retracting the lower pole of the kidney. Now you wanted to show that with the camera. Yeah, now it is seen. Very meagerly seen.
There is-
Okay, now you inserted there and left it. This one. If you want to bring, you can bring it forward also later on. So that completes. Thank you. Dr. Hemnath, what in relation to the pediatric, what is this case is around 3 years baby with reflux. So in this case, where did you put the place? Where is the head end of the patient?
So this is the head end of the patient, foot end of the patient.
Okay.
Any pelvic surgery, little bit of lithotomy, even in pediatric cases required for the camera arm to come inside.
Lithotomy, okay.
So here the important aspect is we cannot keep our port close to the umbilicus. Because
Okay.
the length of the abdomen will be small.
Okay.
Our target is here.
Okay,
So minimum, as I told, minimum 12 to 15 centimeter.
okay,
So it will come in between xiphisternum and the umbilicus.
okay. What about the two other ports as lateral as possible?
This is 8 to 10 centimeter.
So abdominal girth should be minimum 16 centimeters in any child to operate.
Yes, sir. 8 here, 8 there.
This is for pelvic surgery.
Pelvic surgery.
Same thing if it is for the pyeloplasty, how do you place?
So we cannot.
Midline.
Midline. It will be midline.
Just above the umbilicus.
Yes, sir.
And then on either ports 8 centimeter.
Yes, sir.
See, normally in this child of 3 months, what is the vertical length? Can you show, Soundarya?
So this is the.
From here to how much it is there? Vertical length up to xiphisternum?
It's around 27 centimeter.
27. That means even a newborn baby can be done robotic surgery, like world is doing already robotic surgery with this SSI mantra also.
Yes, sir.
Okay, thank you. And docking is same.
Docking.
You don't feel any clogging of the these arms.
Classing, once you keep 8 to 10 centimeter between the ports.
There is no
classing
problem.
It's not a problem.
Thank you.
These are various sports photos, sir. This is for nephrectomy or any partial nephrectomy.
Okay.
This is for the right side nephrectomy or partial nephrectomy.
Okay.
So this is for the left side, as we have shown in the video.
Okay.
The four arms we are using. This is even nephrouretrectomy can be done with the same configuration without undocking. So usually multi-quadrant surgery is difficult, but we can adjust and little bit port placement. You have to slightly skew in the angle, oblique angle, and then we can do without undocking. This is for nephrouretrectomy on the left side. And this is for radical prostatectomy, as we discussed, the camera port in the center, two ports on the left side we are keeping. This is for the left working port, and this is for the extra arm, fourth arm we are keeping in the almost in the lateral abdominal wall line. And the right side, this is there, and two assistant ports in between the working ports. This is for radical prostatectomy or any pelvic surgery with four arms. This is VVF repair. Usually we don't require a fourth arm for VVF repair, except for radical prostatectomy and radical cystectomy. We don't use the fourth arm. So this is a pediatric, as you can see, the difference between the previous one and this one. So this is close to the umbilicus in adults. Whereas in pediatric, we are going away from the umbilicus. You can see the distance between the umbilicus and the camera port. That is the only difference. You have to go away in pediatric patients. So you can see almost very close to the xiphisternum, in between xiphisternum and the umbilicus.
Yes.
And pediatric pyeloplasty, as we told, it will be very close to the midline. So all our ports you can see in the midline here. And the assistant port will fall on the opposite side sometimes.
Correct.
And this is the smallest baby that we have done, 4 months baby. This is for the right side pyeloplasty. So camera port almost at the umbilicus, and these are the working ports.
Okay. Anything
Yes.
more, Hemnath?
Yes, sir.
Over?
Yes, sir.
Can I stop sharing the screen?
I will stop, sir. Yes.
Yeah. So now 2-3 questions Krishnamurti has asked. Difference between the laparoscopic ports and robotic ports. We have discussed in the beginning part of only very clearly. The robotic ports tries to be in a lazy U position or a straight position. At around
15 centimeters from the target organ with a gap of 10 to 8 centimeter between the ports. Laparoscopy is totally dependent on the surgeon and surgeon. Height of the surgeon, height of the patient, target organ not too far away, not too nearer, right hand and left hand separated by 45 degrees. Preferably, the ports will come in front of the camera, whereas in robotic, they come in one line mostly. They come in front in such a way that it will be like a baseball position. Both in laparoscopy and robotic, the assistant ports fall either behind, whereas in robotic, you cannot keep anything in the front. Whereas in laparoscopy, you can keep in the front like in iliac fossa to retract in opposite direction. That is fine. But in robotic, you cannot keep ports in front of the arms, primary arms, because robotic structure will come. The other question asked by Harshavardhan Gowda is, any specific reason to use Palmar point for Veress needle? Hemnath, you wanted to say that Veress needle can be inserted in other places also?
Yes, sir. All other places are all fine. We are used to this position. In this point, we feel it is safer. And also, most of our nephrectomies, we cannot go in the midline comfortably. Palmer's point is comfortable for us.
For us, we are
Other
using Palmar
positions are
point.
also fine. That is personal choice.
Umbilical line is also good. I
Yes,
have
sir.
worry of putting
Inferior epigastric injury.
epigastric artery. So that's why we routinely are using Palmar. And the advantage is 2-click sounds will come.
Yes.
Sudden going the Veress needle inside and hitting a major vessel is not possible. Either liver, spleen, or omentum will
Bowel.
be
Yes.
bowel unlikely. Omentum, liver and spleen we inserted, but that will not cause torrential injury. But vessel injury below the umbilicus or major vessels are superficial, so we don't want to use that. The other question is why only open method? Why not used Hemnath? You can use open method also.
Again, open is completely safe and personal choice, sir. We cannot say it is better and closed is better. It's personal choice again.
Person choice. So open and closed is totally different. I have seen Dr. George P. Abrahams are doing all surgeries open method with the proper meticulous cutting of the rectus sheath under vision. In fact, under light card vision retraction with a small retractors, retracting and then separating with a gauge piece and then incising the peritoneum, then putting it and then suturing and then putting a gauge piece and gauge piece suture and then
Also we have to take.
stay.
Gas leak is possible. We have to take
Gas leak is
proper fixing
possible.
sutures.
So for us, we also have faced one or two problems. The secret is, as Hemnath showed, left hand is controller. When you are inserting screwing movements, and sudden loss should never happen in laparoscopy. Even then, I had recently also in live workshop, small vessel at the omentum got injured accidentally. So every case is different. One small trick is if you cut little anterior rectus sheath, the blunt ports can be inserted better. Sharp ports, you need not cut the rectus sheath. What do you say, Hemnath? Sharp ports are like a metal ports I never use. Metal ports, when you are using, you should be under
First
vision.
blind port, better to use a blunt one, sir.
Yeah, first blind port, better to use blunt, in which you have cook. You have a lot of plastic type of material where the tip is metal port tip is very, very sharp. Any structure, if you hit, it will tear and cut. So intestine, IVC, aorta, it is a disaster. So you should be very careful. Lot of Indians use metal ports. A lot of people are lucky and experienced that they do after adequate pneumoperitoneum. So we had a talk in pure urology also, the port positions in laparoscopy in detail by me only. This is actually I have missed only one video clip where the camera port, I was explaining how the robotic arm comes and how the clutch moves. I wanted to clarify that, Hemnath. In the
Yes, sir.
robotic arm, when you move the robotic arm in SSI mantra, the gross movements are done with the port clutch,
Yes,
or
sir.
gross movements means total arm coming towards nearer to you, total arm going away from you, flexion at the elbow
Height
joint,
adjustment.
a height adjustment, forward, backward, and the hinge at the elbow are all adjusted by port as
Port
well as
clutch
the
and also arm clutches. Yes,
arm
sir.
clutch. These are the two clutches, port clutch and arm clutch. With experience, everybody will get that. It is just not described in theory. Whereas most important last part for fine movement is the instrument clutch. That is very important at the end only. That instrument clutch has to come horizontally over the abdomen of the patient so that two locking points will come at one. Then he will click it. Dr. Hemnath is very experienced in this in SSI mantra because he has done most of the cases, and others are also learning now in our team. It is not a big task. Only thing we had is the SSI mantra 2. Now we upgraded the console SSI mantra 3, whereas the arms we have to upgrade, they are very slimmer. Where I think Da Vinci is a single unit which all will come from the top as an arch, and in bedboard also they come like a arch. There also the movements, clutch, all these things may be same, but here one arm has to come. There one arch will come and then you will readjust all that. There all depends on the basic structure of the mission. So with this, I think this presentation will be useful for those who are using SSI mantra, for those who are using laparoscopy, both general surgery and urology, because these robotic missions are used not only by urologists. That's why we kept this presentation. After doing 220 cases both together, we thought we will share our knowledge through a pure urology platform. So once again, I thank Hemnath for
Thank you so
consistently
much.
learning and properly using in various difficult clinical scenarios where I was using surgery, he was doing surgery, clashing of the arms, sudden movement of the arms. I used to do a little bit roughly, sudden clashing of the arms comes, then he will readjust and say that this particular movement don't exaggerate. Using fourth arm is tricky in SSI mantra now. And of course, the present small thin arms, maybe it is easy, but you should know that when you're using forearms, there should be some space for the lateral movement. If the lateral movement crashes, they are heavy arms and the energy created in movement with the movement is very heavy and the arm can break down also. One should be careful with all these points. Thank you, Hemnath, once again.
Thank you so much, sir, for the opportunity. Thank you, sir.
Thank you. So we'll conclude the session with this.
Yes. Thank you,
Okay.
sir.
Thank you.